Good evening and welcome to Macular Disease Foundation's final webinar of the year, focusing on geographic atrophy and the changes that are coming to the management of AMD for our patients. My name is Vicky. I am the Healthcare Relations Manager at Macular Disease Foundation, and I'm also a practicing optometrist in DY, New South Wales. Before we begin, in the spirit of reconciliation, and on behalf of MDFA, I would like to take a moment to acknowledge the traditional custodians of the country throughout Australia and their connections to land, sea, and community. We pay our respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So firstly, I'll just go through a little bit of housekeeping. All attendees' cameras and microphones have been turned off. If you have any questions, please enter them via the Q&A icon at the bottom of your screen. Your questions will be answered at the end of the presentation, but feel free to type them out as we go at any time. The webinar tonight has been accredited for 1 CPD hour by Optometry Australia, and the learning objectives are on the screen, and you can see them there now. Before we begin, I'll just go through a little bit of information on how we support you, optometrists and orthoptists, on the important work that you do. We have created a bit of a one-stop shop for everything macular disease related. By scanning the QR code on the screen, it will take you directly to MDFA's health professional page. I encourage you to jump on and have a look, as there are many useful resources for your patients and for your practice. You can also find a range of accredited CPD courses. Complementing tonight's webinar is a new chairside guide to managing geographic atrophy, and it includes a handy set of frequently asked questions that your patients may ask you in the consultation room. So, without further ado, I am delighted to introduce Professor Robyn Guymer, a leading expert in Australia and the world on age-related macular degeneration, or AMD. Robyn is Professor of Ophthalmology at Melbourne University and a Deputy Director of the Centre for Eye Research Australia. She is also a Senior Retinal Specialist at the Royal Victorian Eye and Ear Hospital. She is a clinician scientist who leads a team of researchers primarily investigating AMD and has co-authored over 400 peer-reviewed papers. Robyn is an inaugural Fellow of the Australian Academy of Health and Medical Sciences. In June 2018, she was awarded the Member of the Order of Australia for significant service to medicine in the field of ophthalmology, particularly AMD, as a clinician, an academic and researcher. And in 2021, she was inducted into the Victorian Honour Roll of Women. Please welcome Professor Robyn Guymer. Robyn, I will hand over the controls to you.
Thanks, Vicky. Terrific. I'm hoping everyone can hear me. Thanks for coming, everyone, and for MDFA for organising this webinar. I'm surprised we only get 1 point for this. Surely it's the most important thing you're going to do this year, so I'd be asking for 2 points at least. Anyhow, it's Tuesday evening, so thank you all for giving up your evening to listen to me. We're going to go through the changing landscape in geographic atrophy, and surely there's a lots that's happening, which is fantastic. So currently in Australia, there are no approved treatments to prevent geographic atrophy, slow its development, or once established, slow its progression. However, there are 2 novel interventions recently approved in the US and several others in late-stage clinical trials. When the first treatment is approved in Australia, it will completely change the lives of those with AMD and for all of us who manage people with AMD. Who to treat, when to treat, which eye to treat, and with what treatment are all major questions still really to be answered. It's not going to be as simple as treatments for neovascular AMD, because in neovascular AMD, pretty much you treat everybody. Here, we're going to really have to think about the individual and their circumstances. But we all need to get ready to take on this treatment, which is exciting. And so let's see what we can learn tonight. So I think just to start off with, I'd like us all to just talk about the same AMD the same way. And so this is how I like to think about AMD, and it's called the Beckman classification. So we can see here over on the left, we have drusen and pigment changes in this macula. And this would be called high-risk early AMD or intermediate AMD. And then as things progress, you get two forms of late AMD, either the neovascular complications or the geographic atrophy or dry AMD. And really without treatment, you can see far on the right, you end up with...
Robyn, sorry to
Yep.
just jump in. We can't see your slides at the moment.
Oh, sorry. I wonder why that is. Stop share. Share. What about now?
Yeah,
Okay.
perfect. Thanks.
Okay, terrific. Okay, sorry about that. Let's go back. Yeah, so on the far right, you can see the end stage of the disease. So without treatment, you end up clearly with very poor central vision. So that's the Beckman classification. And I think as we go forward talking about dry AMD, much better if we just use dry AMD to mean the late stage of geographic atrophy, and before that, use early or intermediate AMD as the earlier stages. So Australia is ageing. We have 1 in 6 Australians now over the age of 65, which is over 4 million people. And so it's estimated that amongst those, 100,000 Australians will have geographic atrophy. And a recent impact study revealed that the financial cost associated with GA related to the vision loss in Australia exceeds $1.8 billion. So a major impost on our health system. So when we think about geographic atrophy, it's always been traditionally defined as what you see on a coloured photo or when you look in, examine the back of the eye. So on your left, this colour photo, you can see hopefully sharply demarcated pale lesions, and you can see the choroidal vessels in the base here. But maybe you would agree with me that it's very hard to actually outline where it begins and where it ends. So that's why we've sort of turned to fundus autofluorescence, which you can see exactly the same eye now on FAF on your right. And hopefully you would appreciate that you can demarcate really very exactly where the RPE cells are missing. So where it's black, there's no RPE cells, there is virtually no vision there. And so geographic atrophy has sort of moved to also being defined on the basis of this image, where you have to have these really sharply demarcated black areas of hypoautofluorescence and also have a corresponding pale lesion on the colour fundus photo. So the autofluorescence has really become indispensable. And you can see here, if you look along the lines, it's the same eye over several years. So FAF is a fabulous way for you and your patient and their family to sort of see what's been happening over time. So hopefully you can appreciate in that top one that really over 3 years, the areas of atrophy have actually increased quite substantially. You can also tell if it's multifocal or unifocal very easily. And again, in the bottom set of images, it's a unifocal lesion. And in my mind, that really hasn't changed a lot over 3 years. And that becomes very important when you're thinking about whether you want to intervene. Because not all geographic atrophy grows at the same rate in each person. And so monitoring growth rate over time, autofluorescence is a great way to do that. And I think will become an important consideration when we're working out whether or not to recommend treatment to our patients. Autofluorescence also gives us much more information. So now we're looking at the background autofluorescence. And it so turns out that that can give us a hint as to the growth rate. So over here you can see what are called focal, banded and diffuse trickling backgrounds. And basically the more increased autofluorescence you have in the background, for example, in that second banded example, is a high risk sign for growth. So the focal lesions, these odd little ones, probably don't grow very much, but it's where you get this diffuse banded pattern, or what's called the trickling, where it's all sort of abnormal past the area of atrophy, that you can get some hint as to what the growth rate is likely to be in these patients. And then in the second row of pictures, autofluorescence really helps to differentiate geographic atrophy secondary to AMD from inherited retinal diseases. And this is proving very difficult, particularly when we see patients at the end stage of their atrophy where there's not a lot of other clues in the eye, that a lot of people are being enrolled in GA studies that potentially don't have the AMD as the underlying cause, but more inherited disease. And so here, hopefully you can appreciate that the autofluorescence really looks very different down the bottom than it does on the top. And so these are very typical, very bright background hyper-autofluorescence that you see in inherited retinal diseases. And so this is very important now that we have treatments that potentially don't work in inherited retinal diseases and do work in geographic atrophy, or vice versa. When there's gene therapy for inherited diseases, you don't want to be put people with geographic atrophy into those treatments. The other thing with autofluorescence is how now in trials they measure the size of a lesion, which makes you eligible or not to get in, and that's how they measure whether the drugs are working, by taking a baseline size and then seeing change over time. So you can get these programs that outline all the atrophy, and then you add them all up, and that's how you work out the growth rate of these lesions. So this has become the outcome variable in pretty much all the clinical trials to date. So with all those imaging characteristics, you can actually get a list of things that are associated with faster growth of the geographic atrophy. And so here, if you've got both eyes with geographic atrophy, it's likely to grow faster than if you only have one eye with atrophy, the other with drusen. Lesions that are not at the fovea tend to grow faster than those that are under the fovea. Multifocal lesions tend to grow faster than unifocal lesions. And then there's sort of a Goldilocks size, not too big, not too small, as the faster growing lesions, so intermediate in size when you add it all up. And then this reticular pseudodrusen, which is a relatively new appreciation of a different deposit in the eye that appears to increase risk. So I thought we should perhaps just refresh reticular pseudodrusen before we move on. So this is what you might see when you're looking on a coloured photo. Reticular pseudodrusen are often this sort of net-like, very pale, very easy to miss, pale lesions throughout the macula. And this is just showing you a coloured photo, an infrared and an autofluorescent picture, and how often you are to miss them. So colour fundus photo, or just looking in, you potentially can miss half the eyes with this, whereas the other two on-fast images, near infrared and fundus autofluorescence, will give you these very pretty pictures of reticular pseudodrusen. But primarily you would identify these on OCT. And that's because these deposits are very distinctly located compared to drusen. So here's an eye that actually has both conventional drusen and these reticular pseudodrusen. So indeed, this middle OCT scan, these are conventional drusen, they occur under the RPE, whereas the top one is showing you these deposits that are clearly above the RPE. So that's really how you tell the difference. You find the RPE and work out where the deposit is. So these that make the ellipsoid zone wavy are called stage 2 reticular pseudodrusen. And then down the bottom, these are much bigger mounds. They break through the ellipsoid zone and out external limiting membrane, and they are stage 3 reticular pseudodrusen, which on the colour photo are those tiny little dots, which previously we might have thought were just small hard drusen, but end up being much more risky reticular pseudodrusen. And you can see on the colour fundus photo, potentially you'll see the little points, which are the top of these little pyramids, but we would completely miss this stuff up the top, which are these wavy patterns of reticular pseudodrusen. And so these are the stages which people have identified. We don't really know, is it worse to have a 3 than a 2? We don't know that yet. And they do go away like conventional drusen, and they leave these sort of little thickened deposits, which you would not really know they were reticular pseudodrusen unless you'd seen it before. and know that that's the end stage of the reticular pseudodrusen. So let's talk about treatments then. So we're all very familiar with treatments in the late neovascular form of AMD. You wait for CNV to occur or macular neovascularization to occur, and then you treat. What's new now is that potentially we have a treatment once you've got geographic atrophy that started, which is how the trials were run. You had to have some geographic atrophy to start with, and the idea is to intervene at that point to try and slow down the growth of these holes. And so, as I was mentioning before, in the trials you had to start with, on autofluorescence, a certain amount of black holes. So most trials you need more than a disc area of, when you add it all together, of atrophy. And the aim was to shift the slope of growth. So rather than have the fast natural history, the hope in these studies was to slow down the growth of these holes. And so this is exactly what two treatments were able to do. They're called Syfovre and Isove, and they are two approved treatments in America. So let's look at where these treatments are trying to intervene. So these two, plus most trials underway, look to block inflammation in the eye. So there's a lot of evidence suggesting that inflammation, but in particular the complement pathway, which is activated during inflammation, drives progression of disease. I don't think any of us are certain or possibly even think that it causes AMD, but the concept is that when you've got those drusen, there's an inflammatory focus, it can't be turned off, and thus you get cell death and atrophy. So the two approved drugs are intervening where I've put my black arrows here. So Syfovre is the first one that was approved in America, and it blocks the C3 molecule, so it's an anti-C3 drug. And then Isove blocks what's called complement factor 5, which is a bit further down the complement activation pathway. And basically there are pros and cons, I guess, of where you might want to intervene, but the end result is trying to dampen down the activation of what's called the MAC attack protein, which is down the bottom, which causes cell death. So they are the two drugs that have been approved. So let's look at the first one, the anti-C3. It's called pegcetacoplan or Syfovre. And so it's the one that has the most data to support its effect. So, and was the first trial in geographic atrophy. So in this study, you had to enroll not too big, not too small, so around 1 to 7 disc areas of atrophy. It could be either in the middle, so under the fovea, or not under the fovea. But you did have to have some signs of that hyperautofluorescence we talked about, because it was a sign of more fastly growing lesions. So of course the trial, they wanted people that were growing fast, and so that's how they tried to optimize that growth. And so over 1,000 people were enrolled, so quite big studies, 200 sites internationally. And the drug was given every month as an intravitreal injection or every other month. So there were two arms, monthly or every other month. And as we said, the endpoint was based on the growth rate of those atrophic lesions. So these are the summary results of 2 years. So the grey line is the growth rate of the sham group, and the two graphs are the two different international trials, Oaks and Derby. And so the treatment arms are the bluey colour and the orangey colour or browny colour. And you can see that the slope is minimally, but it is statistically different from the sham group. So the idea is that these lesions are growing less fast with the treatment compared to without. There's not a lot of difference at all between having it every month or having it every other month into the eye. And at 2 years, they were both significantly different. Interestingly, at 1 year, you can see at the beginning, the slopes take a long time to diverge. And so in fact, in Derby at 12 months, it wasn't statistically different, but at 2 years is. And the thought is that perhaps you can't save cells that are destined to die in the first 6 to 9 months, and you really only see saving the cells after that time point. So that's the basis for which a treatment was approved in America was this ability to slow down cells from dying. When they looked at only those that were not under the fovea and those that were under the fovea, there actually was more benefit if you weren't under the fovea when you started. It seemed to slow down the growth better. And you might remember we said that the ones away from the fovea grew faster, which you can see here, the slope is steeper. And so the drugs seem to work better in those cases. And when you can use these AI algorithms that are around now to actually measure the thickness of the photoreceptors on your left and the RPE thickness on your right, you're starting to see perhaps more benefits. So again, the grey is the sham group. In the left eye, we're looking at the loss of photoreceptors measured by AI imaging, and hopefully you can see quite a dramatic saving of the photoreceptors, lesser loss. So the graph is plotting the loss of those photoreceptors. And then on the other side, the RPE, not quite as much difference, but again seeing that the treated groups maintain more RPE than the sham group. However, having said all that, when they actually looked at the vision after 2 years, no difference. So injecting someone every month or every other month and slowing down the rate of growth of the atrophy actually made no difference to the vision. And not only that, made no difference to reading speed, microperimetry, anything that they looked at, there was no difference. So that brings us to this slide. And it's really, if you understand this slide, you're better off than the Europeans who actually cannot get over the fact that the vision was not different. So you can see here in my example of quite fastly growing atrophy, the visual acuity is still 6.6 throughout because the fovea is still spared, which is often the case. And so I don't think anyone could argue that that lesion is not growing and that it wouldn't be a good idea to stop it from growing. But if all you cared about was vision, then you will say that there was no difference over 3 years, so why bother? And that's the pickle that we're in at the moment with both these trials, is that the nature of the disease, unlike neovascular AMD, is that not always is visual acuity the best measure of efficacy of these drugs. And not only that, so that's the one problem, is that when you're trying to get these approved or talking to a patient suggesting they have the treatment, you have to explain that actually visual acuity may not change. And here's another issue, is that the rate of getting neovascular AMD in treated eyes, so if you look at the first column, that's per month or per every other month versus sham, there was a marked increase in the rate of neovascular AMD complications. So 12% of the monthly, 6% of the every other month, and 3% of the sham. So really a very nice dose response. The every month got twice as much as the every other month, which was twice as much as sham. So this is a problem. So we have to explain to people with geographic atrophy that by having the treatment, we may actually increase the risk of neovascular AMD, which is fine. You can have that treated as well. But of course, that's another lot of injections into the same eye. And then risks of inflammation or infection. So I suppose if you just look at the endophthalmitis, which is the bottom row, there was not, it was just what you would expect, a couple of cases of endophthalmitis in 1,000. So not pretty much regular. But then there's this inflammation. And so again, we see in the monthly group, almost 4% had some inflammation intraocularly. Every other month was 2%, and basically none for the sham. And so herein lies another problem, that there seems to be a predisposition to having intraocular inflammation. Now in the trial, that was all, and they settled quite well with steroids. But now when we go to the real world, so in America, the drug was approved 18 months ago now, February 2023, and there have been reported these quite dramatic cases of severe vision loss as a result of retinal vasculitis. So I've got 7 here. There may be a couple more, but not many more, so few, but some of them have had irreversible severe loss of vision. And they reckon it's about 1 in 4,000. Tends to only happen with the first injection. It's some immune mediated thing in people, and you can't predict who. And so if you can get past the first injection, then you're okay, but it's that risk of that first injection that's the issue. And so as a result of what I've just told you, the Europeans have said, no, we don't want to approve this drug. And they've actually been asked 3 times and 3 times said no. Whereas the Americans seem to understand that saving cells from dying has got to be a good thing. And they didn't need to be shown that in and of the trial, they improved vision. They can understand that, it's the commonest cause of poor vision. And people over 50, you are going to lose vision. It's got to be a good thing to slow that down. And in Australia, we're waiting for our regulatory bodies to decide which way they're going to go. And we don't know the answer to that yet. So the second one, very similar, is the one that's blocking the complement factor 5. So just a bit further down that pathway, IZERVAY. And so their trials were called GATHER1 and GATHER2. And they did not have nearly so many patients. So 200 in the first one, 400 in the second one. So many fewer patients than the pegcetacoplan. And this is monthly injections. There was not a every other month arm. So it's monthly versus sham. And I think that the results are, very similar, same sort of slope change, nothing too dramatic, but a statistically significant difference in the slowing of the growth of the GA. And that was 12 months. This is 18 months again, getting a slightly bigger gap between the two. And they actually had 2 doses, 2 milligrams and 4 milligrams, not showing a lot of difference in the result. So again, a significant difference compared to sham, which is the dotted line there. So their endophthalmitis rate was very small, which is terrific. They do have an increased risk of neovascular disease in the treated group. We can see here, they had 2 different names, neovascular AMD and CMV, but if you combine them, we've got 11% in the 2 milligrams, 15% in the 4 milligrams versus 2 in the sham. So again, similar increased risk of neovascular AMD, and we can talk later, if you like, about why that is the case, but that seems to be pretty consistent across the 2 treatments now. They were able to show that they could save vision. Again, there's what's called post hoc, in that it wasn't thought of when they defined the study, and some people will poo-poo the result because it was thought about after the study had finished. But here we're looking at the ability to reduce losing 15 letters of vision, and those in the treated arm kept their vision better than the sham. So more sham lost 15 letters versus the treated group, and that was significant. So they had approval 6 months later than the Syfovre in America. So they're both being used now in the States. They don't have an outcome from Europe yet, and nor in Australia. So there's much more going on as well. So they're the only 2 that have been approved in America, but there's lots of other interesting trials. So these ones here also look at the complement pathway, and I've put my arrows where they want to intervene initially in the pathway. But what's interesting is that they are systemic treatments, not intravitreal treatments. So this way you could treat both eyes at the same time. So the first one is a complement factor B inhibitor that's given by subcutaneous injections. And the second one is complement factor H inhibition, which is given as an oral treatment. And Australia was involved in both of these trials, which are still to read out yet. And then the third one I've put there is not a complement inhibitor. This one works, it's an oral tablet, and it works to try and slow down the visual cycle in the hope that reducing toxic byproducts of the visual cycle may mean that the RPE is less affected, and so the disease slows down. So that's a novel intervention, it's oral, and it's still ongoing, it's still recruiting currently in Australia. So what about gene therapy? So the idea is that rather than having to give injections every month or every other month for forever, what if you put in a gene that made those complement factors that you are replacing with the injections? And so there's several different gene therapy trials underway or finished. So the first one was this need to actually go to theatre and have what's called a subretinal bleb of virus that delivers the gene. And it again was targeting the complement pathway. It was delivering complement factor I that actually dampens down the complement pathway. So it was stopped stopped before it was supposed to because of thought of lack of efficacy. So that's a pity. We all think they called that too soon, but that finished. Currently, there are studies where the gene is actually given as an intravitreal injection, so much easier than having to go to theatre. So it's a simple injection, just like the anti-VEGFs, and they similarly are blocking the complement pathway with slightly different methods, but at the end of the day, they're trying to, again, dampen down inflammation. And both of those are still underway, certainly at the Centre for Eye Research Australia and potentially in Sydney. But gene therapy, you can't do it everywhere. You have to do it at approved sites. And then what's perhaps coming, not yet in trials that Australia is involved in, so earlier studies, usually in America, is to try and replace cells that are lost. And the cell that people are trying to replace is the retinal pigment epithelium. And there are different sort of techniques, whether you sort of squirt in the RPE cells or you put them on like a little layer, which sort of pretends to be Brooks membrane, and try and slide it in. But the idea is that you replace the areas of atrophy with RPE cells, and somehow then the photoreceptors come back. It's probably a little while off yet. So then the question is, are we ready in Australia, and everyone here online, are we ready to sort of find these cases and be ready for when one of these treatments is approved? And to address that, I thought we should go through what the OCT looks like when you start to get atrophy, because this is possibly now a very good way to pick up earlier stages of atrophy that you might then want to send for an opinion. So we're all used to looking at fungi with color photos, or when you're looking clinically, and this basically is the same eye over many years. On the left, you see high-risk features, drusen and pigment change there. And after a number of years, in my black square, there's a bit that's missing, which is this eye's developed geographic atrophy. But we know if you had the OCT, you would see a lot of changes that you're just not picking up. So again, here on the left is what that eye looks like, and on the right is when atrophy has happened. And so the question we had as part of our research many years ago was, what does the atrophy look like as you go from drusen to missing cells? And so if we just remind ourselves what a normal OCT looks like, and in AMD, we're really concentrating on the outer retina. So those bands that represent the RPE and the photoreceptors. And also, of course, we're interested in what the choroid looks like. So here is a picture of really quite high-risk drusen and pigment clumping here. It would be called intermediate AMD. The OCT here shows the drusen, so it's under the RPE. You can see the pigment sitting on top of the drusen, and this puts this drusen at quite high risk of progressing to geographic atrophy. So we wanted to know now 10 years ago, what does a druse do when it disappears? And if you just quickly show this video, if you keep an eye on the druse, you'll see that the material goes away, and you get this collapse of the retinal layers. We call it subsidence. And so we wanted to articulate what we were seeing to help everyone understand that was the beginning of cells dying and atrophy. In addition, there was an international group of experts that got together with the same aim, really, to try and put into words what are the things that you see on an OCT when you get atrophy. And this is where the term C-RORA and I-RORA come from. So RORA stands for RPE and outer retinal atrophy, to try and encapsulate the layers of the retina that are involved in AMD. So you can see here, this is a example of complete RPE and outer retinal atrophy, or C-RORA. So to get that, you have to have a region of hypertransmission, which is at least 250 microns in length. So here, a very nice example of the hypertransmission. You have to have a corresponding zone of where the RPE is either missing or attenuated. And hopefully you can see in that example, the RPE sort of stops short and then starts again on the other side of this patch, this lesion. And then you have to have some evidence that there are photoreceptor bands that are lost. So here we can clearly see that there's no ellipsoid zone, no ELM, the outer nuclear layer is sort of missing, and you get this collapse of the outer nuclear layer, outer plexiform and inner nuclear layer. So that defines C-RORA. And if it's not 250, then it's called incomplete RPE and outer retinal atrophy. So here is an example where we do have some hypertransmission, but it's not a consistent 250 microns in length. The RPE is looking pretty crappy, but again, you wouldn't be able to necessarily agree that that was all 250 microns of missing RPE or attenuated RPE. But there's certainly evidence of photoreceptor loss. So you don't see the EZ or the ELM, the outer nuclear layer is very thin. And so it meets the definition of this incomplete RPE and outer retinal atrophy. So when we were looking before those C-RORA and I-RORA terms came about, we identified changes which were highly predictive of going to geographic atrophy. And this is this thing called nascent geographic atrophy. So many cases, they are the same as I-RORA or C-RORA, but really, if you have the features of nascent GA, the risk of going on to GA is very high. And so nascent GA is where you actually see the subsidence of the inner nuclear and outer plexiform layer, which hopefully you can see there on the top. You sort of see the layers coming down. And then this wedge-shaped band is also another sign. So you don't need both, one or the other is fine, to have this really high-risk feature of going on to geographic atrophy. And I've just put here a few more examples. On the left, we've got both the wedge and the subsidence. But on these other examples, we have wedges with no subsidence and subsidence without necessarily the wedges. So one or the other is more than enough. And when you have them, the risk of going on to GA is about 78-fold that of if you don't have that. So thus in an eye that you may see in the clinic with what you think is intermediate AMD, drusen, pigment, there's not a lot to see on the autofluorescence. There's a little bit of a scratchy black line. But when you look at the OCT, they may very well have already the beginnings of atrophy, which you can see there on the OCT. And in fact, when we look at people with bilateral large drusen and pigment, about 1 in 5 eyes will already be, on the way to atrophy. And so they're the sort of cases that going forward, when we have a treatment, we may very well want to start a different conversation. So the idea now is we're still awaiting, seeing whether we get approval in Australia for these treatments. And if not these, the next ones that will come along, surely soon we will get some treatment, is that we really need to start imaging our patients now so that we have the best information available to guide them on whether or not they need treatment. So ideally, and I've written this in an editorial, is we would really love autofluorescence and dense OCT scans because it's going to help us counsel the patient about their growth rate, and also help us make sure we're dealing with geographic atrophy and not inherited retinal diseases. And ideally, you would have these images at the place where they're going to come the next time to talk about treatment. So ideally that they're at a place where we can manage GA as well. And then also, if you identify people with GA, you may well want to refer them to a trial. So to this end, we changed, or we revisited the collaborative care referral pathway for optometry earlier this year. And there's just been a change in the bits to do with geographic atrophy. So basically, the main essence is that if you have someone with geographic atrophy who is at all interested to find out if they're suitable for treatment or would be even considering treatment, we would like them referred non-urgently to an ophthalmologist so that they can do the baseline imaging, ensure they don't have inherited retinal diseases, and then establish a plan for review regarding treatment. If they're not interested, they don't want to know about treatment, they go back to the the managing optometrist. But if they're interested in treatment, then they would stay and have that sequential imaging until treatment is available. And so this is my second last slide, there are many facets of treatment still to be worked out. Unlike neovascular AMD, where virtually everyone gets treated, this won't be the case. You can't individualize treatment. Everyone's going to need regular ongoing injections at the moment, forever. And even with treatment, the vision is going to get worse. It's just going to get worse more slowly. So you really have to set expectations. So who to treat and when to treat needs careful consideration, and we'll need to sort of take the whole person into account. What are their visual needs, their age, their life expectancy, and that's going to be a conversation with the patient and their carers. And so given that we've got so much more to work out, there is still the need for trials. Clearly those two treatments with ongoing injections that have a modest improvement in the slope of growth is not the end game. It's the beginning, which is a very important beginning, but we still got many things to ask and answer. So we would certainly, if you've got a patient that might be interested in trials, they are still actively going on around Australia to find out who does trials near you, and then hopefully refer them in. And indeed, very soon there will be trials, including our own currently, looking to even intervene earlier in intermediate AMD. So just to be aware of what's going on so that you can offer your patients the possibility of getting treatment long before it will be available to everybody else. So I will end there and hand back to Vicky and stop my sharing.
Thank you so much, Robyn. It really feels like this is a significant period of change that we haven't seen for quite some years. So we really appreciate that you're giving your expertise and your time tonight to help us prepare for what's ahead. I'm just going to share my screen again. So I can see questions are already coming through, which is great. So while Robyn, I'll give you a moment to have a look at the questions as they come, and I'll just run through a few things from our side of things. So I've just got the QR code up on the screen again. This is for our geographic atrophy chairside guide. So if you want to just have a look through that again, it will go through a lot of the points that Robyn touched on this evening, and you can see the QR code there on screen now. I'd also just like to go through our new patient support service, which is called iConnect. Hopefully many of you here will have already heard about it, and you might even already be referring your patients in. We've taken various research channels to develop this service. We listen to the evidence, and we've brought together our traditional ways of supporting people into a tailored service for your patients. So we provide support in 3 different ways. We improve your patient's health literacy by providing relevant treatment disease information for them. We also provide practical advice for living with their stage of AMD and any vision loss that they might be experiencing. And lastly, but possibly most importantly, we provide your patients with emotional support. Our team connect regularly through phone calls or emails and have been trained to address the worries and concerns that people may have about their diagnosis. We can also connect people to peer support groups in person or online. We will stay regularly connected with your patients, usually for around 12 months or as long as they wish to remain in the programme. So the service launched in May officially this year. So we've already done an evaluation. We do love our evidence at MDFA, so we'll continue to evaluate the service. But I wanted to tell you a little bit about what people who are using it think about it. So you can see that we've got a whopping 98% of patients who would recommend the service to others. They loved the resources, especially the disease information and the mythbuster fact sheets that we sent out. Accessibility to the resources got a big tick too. It's a little bit early to measure if we've had a positive impact in the long term, but even after a few months, 75% of your patients reported that they were positively impacted. People particularly expressed a need for more detailed information on treatments and low vision and assistive aids, and the phone calls were valued, allowing users to be well informed about their condition and ask any non-clinical questions that they may have in between visits to you. And especially at this time period when things are changing, that's also something that we can provide, is information and the FAQs on geographic atrophy for your patients too. So I'll just go through how to refer your patients into iConnect. We've got quite a few easy ways to choose from, as you can see on the screen. There's an e-form on our website. You can refer via Macular if you have it in your practice. And you can also go with the old school referral pad, which is my method of choice. And you can just tear it off and give to your patients to contact us. To order any of these, or if you have any questions, then please email us through the email address on the screen now. So I'm going to hand back over to Robyn. If you want to turn your camera back on, Robyn.
Yep.
And the questions are coming through.
Sure, I can deal with the first few that I've read. So first question was, tell us a bit more about reticular pseudodrusen and why is it important? So I think so we used drusen and pigment as being risk factors for progression, and some people are thinking reticular pseudodrusen is like the third risk factor that you need to consider when you're thinking about progression. And we do know that those with reticular pseudodrusen are more likely to get geographic atrophy. They're more likely to grow faster and towards the reticular pseudodrusen. And certainly our own study where we used the nanosecond laser, those with reticular pseudodrusen did worse than those with regular drusen. And we know those with reticular pseudodrusen have very poor dark adaptation. So you may recall that patients with AMD have difficulty going to different lighting conditions. They take a long time to dark adapt. And that's really belongs mainly with those with reticular pseudodrusen. And so when you look histologically, the RPE in people with RPD is looking very sick, very dysfunctional. And so the way I think about it is that eyes with RPD are sicker eyes. That they're going to be harder to keep the atrophy away. They're going to be much harder to challenge, and also they may actually have a different cause, and so potentially a treatment for complement, which is more to do with large drusen, may not be appropriate for those with RPD. And at the moment, they're all thrown into the trials. You don't know who's got what, particularly as you get the geographic atrophy, you tend to lose the RPD. So if you've got a big patch of atrophy, you may not know whether your eye had reticular pseudodrusen. But by the time you get GA, maybe 70 to 80% of eyes will have reticular pseudodrusen, whereas when you have intermediate AMD, maybe it's more like 30 to 40%. So there does seem to be something very bad about having a reticular pseudodrusen. There was another question about how do you treat the neovascular AMD if you're treating the geographic atrophy. So none of the trials allowed you to have eyes with neovascular AMD. So it's really just the real world in America. What are people doing? But also in the trials, if they did develop CMV, you could treat both. And so basically they just get both. So often in the trials and now in America, on the same day, you'll get a treatment for geographic atrophy and then you'll get a treatment for neovascular AMD. Remembering there's not a lot of room in this eye, so they're already getting a lot of volume. And so the risk, particularly for these people who are about 10 years older than your typical neovascular AMD patient, the risk of increasing the pressure and snuffing out the blood supply and getting them to have this blackout is quite great. And so I think, we're often asked, well, what would you do? And I think I would get the neovascular AMD under control first, and then I would go back to starting to treat the GA. And we also know that people with neovascular AMD get atrophy. So there are plenty of people in the States that are getting both, not because the atrophy causes the CMV, but because they've got CMV being treated and now they have atrophy. So the two things are going together.
Can I just ask, sorry, Robyn, can I just ask there, is that something in Australia that would have to be approved to treat alongside? So if you wanted to treat for neovascular and for GA here, would that be a sort of need approval, or how does that work?
Yeah, it's a good question, because when you fill in the forms for the anti-VEGF, you have to say it's the sole PBS drug approval. You're not allowed to use two. So I imagine that would come as part of the the deal, that maybe they'll allow us to do both. But you're right, at the moment, you have to say you've only got one PBS funded treatment. And maybe these treatments will be approved in Australia, not PBS funded. But I don't think it's a problem that it hasn't in the trials. There were so few people that got both. I don't think people are worrying that you shouldn't use the two together. I don't think that's a problem. It's just who will pay for them both. There was a question about which one would you choose, the Syfovre or the Izervay, and that's interesting. So the nasty vasculitises with the very poor visual outcome were more with the pegcetacoplan, the first one, Syfovre, but they had many more trial patients, and so there's much more knowledge about how many, the number of people who got treated. And now that we're looking, we actually find some of these vasculitises with Eylea and faricimab, so it's not necessarily only related to these drugs. The more we look now, the more we find. But having said that, the ones with the Syfovre did seem to be extraordinarily severe in just a handful of cases. So I don't know if people in America are going more for the second one because of that. But certainly those cases of vasculitis certainly dampened people's enthusiasm to use it too early. Because when it first came out, I think people were starting, much earlier in the disease than what the trials were doing. And the pegcetacoplan, there wasn't much difference between once a month and every second month, whereas the Izervay, you had to use every month. They didn't trial every second month. So things to think about. No straight answer. So why does the CMV happen? So it's a good question. I think most people are probably saying it's the way the molecule is made. It's got this, what's called a pegylated bit to it, and it's thought that this extra bit that holds the active drug together may be driving it. Personally, I think it's goes hand in hand with it working. So I was always taught that you have to have surviving RPE cells to make VEGF to cause blood vessels to grow. And one would imagine if you're saving the RPE cells with your new treatment, you've got more sick RPE, so they're not fabulously healthy, but they're alive. To me, it's logical that if it worked, you should expect more CMV, because they're there to make more VEGF. Because we were also told when I was taught that the more geographic atrophy you have, the less likely you are to have CMV, because you've got less cells making VEGF. So to me, it's logical that it goes hand in hand. And if you didn't see it, you'd be wondering why not. But still, there's a lot of debate about that one. And then there's a question about light therapy. So there's this interest in red light therapy for AMD, but primarily in earlier stage, so with drusen. And there's been one randomized trial called the SightLight trial, where they report improved vision and slowing progression. I think they need to do some more studies to show, validate what they find, but it is biologically plausible that there may be some improved photoreceptor function, because this red light is absorbed by mitochondria of the photoreceptors, And so the photoreceptors may be sort of getting more oxygen. And so the way I like to think about that is you've sort of put your photoreceptors in ICU for a few weeks. It may keep them alive for longer. They may work a little better, but ultimately the underlying cause has not been addressed. So I'm not sure that it's going to be a long-lasting treatment if it does work. We've got a few more questions.
I think we've got time for a few more. Yes. There's one here. Do you think we'll be able to predict who is at risk of retinal vasculitis in the future?
Good question. So in the trials, you weren't allowed to put people in that had like autoimmune uveitis, and you don't put into trial people that are sick. Yeah, that you don't usually choose them for trials. And you can imagine then when it gets to the real world, everybody is considered. And so you sort of got to say, in all their trials, they never had any vasculitis in any of these studies. Yet when it gets to the real world, you see some. So the thought is you would certainly exclude people that had uveitis or perhaps had autoimmune diseases. So it seems to be an autoimmune inflammation. And that is why it sort of happens on the first injection. So one way we're thinking of handling that is, because potentially you would want to treat the better eye. So you could imagine maybe first eye is lost from geographic atrophy and everyone's desperate to save the second one. But perhaps you would put the first injection into the worst eye to make sure that you didn't get this reaction, and then would go over to the better eye. What the TGA and the PBS would think of that is another story, but that certainly is one way of just trying to reduce that risk of damaging the better of the eyes. There's a talk about public funding and the access. So that's another good question. So at the moment in public hospitals, certainly at the Eye Hospital, we wouldn't see anyone with geographic atrophy. They don't get in the door really. And so how on earth would we cope with a whole new aspect of AMD to treat? And this is certainly something we'll have to put our heads around. And you certainly don't want to take the spot of someone with neovascular AMD or in fact diabetes or vein occlusions, because they are much more needing more urgent treatment than the GAs potentially. So we have to increase capacity, and therein lies a whole body of work in how to increase the capacity to do this, particularly in a public system. And again, just because the drug might be approved does not necessarily mean the PBS is going to pay for it for everybody. And it could be that they will have a little subset that maybe, second eyes or certain vision or certain speed of growth that, may be considered for funding and the rest not.
Well, thank you. Thank you so much, Robyn. It's been an absolute honour to have you presenting on such a specialty topic. And I'd like to thank everyone for coming this evening. It's been great to have the support of everyone else here. And with that, we'll say good evening. I think we're finishing right on time. So thank you very much.
Terrific. Thanks very much. And thanks everyone for listening.
Good night.